Welcome to this explainer. Today, we're taking a pretty fascinating tour right into a clinician's toolkit. Have you ever wondered how a therapist actually decides what to do when you're sitting across from them? Well, in the clinical world, every single intervention has a very specific purpose. They're designed to target entirely different aspects of the human experience. So, we're going to demystify that alphabet soup of therapy today, from foundational relationships to the neurobiology of addiction. Okay, let's dive into this. Imagine sitting in a therapist's office. You're bracing yourself to talk all about your childhood, and instead, they just hit you with this. If you woke up tomorrow and your problem was entirely solved, how would you know? This is known as the miracle question. I really wanted to start here to hook you right away, because it perfectly illustrates how some therapies cut straight through the clinical jargon. Instead of getting bogged down in the deep etiology of exactly why a problem exists, this approach focuses purely on pragmatic, actionable solutions. You literally work backward from your ideal reality. So here is our clinical triage menu for today. We'll start with the person-centered foundation, move into finding meaning and solutions, explore the group therapy microcosm, shift into rethinking addiction pathology, and finally wrap up with evidence-based interventions. All right, kicking things off with Section 1, the person-centered foundation. Unlike highly directive therapies like cognitive behavioral therapy, where the clinician is actively challenging your thoughts, we're starting with modalities where you, the patient, entirely drive the clinical flow. This brings us to humanistic therapy. It isn't just one technique, it's a whole family of allied modalities. And its foundational assumption is incredibly optimistic. It assumes that you possess an inherent drive towards self-actualization, and that you are fundamentally capable of personal growth. The absolute key here is that success relies heavily on an authentic, supportive relationship between the practitioner and the patient. Basically, you can't heal if you don't feel truly seen. So how do you make someone feel seen? Well, legendary psychologist Carl Rogers outlined 3 absolute non-negotiables for the therapeutic alliance. First, a therapist must show deep empathy through active listening. Second, they have to maintain congruence, meaning their body language actually has to match their words. And third, arguably the most important, they must offer unconditional positive regard. They hold you in a strictly non-judgmental light, operating on the assumption that you're just doing your best. Together, these elements create a remarkably safe environment for profound self-exploration. And this brilliantly illustrates our next concept. Think about someone you know who masks deep, heavy emotional exhaustion with this hyper-positive, constantly smiling exterior. Gestalt therapy actually calls this incongruence. The entire clinical objective of Gestalt is to fix that disconnect. The goal is to perfectly align your internal feelings with your external behaviors and expressions, so you can exist authentically right here in the present moment. Now, how does a therapist pull that off? It's a fascinating, intense process. Developed by Fritz Perls, this therapy has a massive here-and-now focus and uses some highly experiential techniques. You've probably heard of the empty chair exercise. That's where a patient directly speaks to an empty chair representing someone they have unresolved conflict with. It forces visceral, real-time emotional processing for unfinished business. The therapist will also enforce strict linguistic shifts, like demanding you use I statements. If you thought therapy was just passive listening, no way. This demands strict, undeniable personal responsibility over your own emotions. All right, so that foundational alliance building is vital, but let's move on to Section 2, finding meaning and solutions. We're shifting gears from the relationship itself to therapies designed to find specific meaning. Imagine trying to find purpose in the absolute darkest moments of unavoidable suffering. That is exactly what Viktor Frankl's logotherapy is designed to do. It guides patients in confronting the grand, heavy themes of mortality and isolation. By confronting that existential anxiety directly, it actually helps patients process profound grief and facilitates authentic living. For a lot of people, this leads to self-actualization through altruism or discovering a brand new life purpose. Other tools in the kit are highly targeted. Take emotion-focused therapy. It operates on the simple mantra that you must feel to heal. It's like taking unaddressed anger, like road rage, and transforming it into healthy, assertive boundaries. Alternatively, interpersonal therapy, drawing heavily on Bowlby's attachment theory, focuses strictly on your relationships right now. It helps you navigate massive role transitions like getting a divorce, moving to a new city, or becoming a new mother. And then we have the ultimate pragmatist tool, solution-focused therapy. Remember that miracle question from the very beginning? That belongs here. Another huge tool in this approach is the incredibly simple 1 to 10 scale. Clinicians use this to pragmatically assess a patient's readiness and internal locus of control. It explicitly avoids diving into the deep etiology of a problem. It just asks, on a scale of 1 to 10, how ready are you to make this change? And hey, what would it take to move you up just one single point? Okay, let's scale things up from individual modalities to Section 3, the group therapy microcosm. Group therapy is essentially a clinical microcosm where patients enact their subconscious interpersonal biases in real time. The pioneer of modern group therapy, Irvin Yalom, found that there are exactly 11 distinct therapeutic factors that make a group setting uniquely effective. I mean, think about the sheer power of witnessing a peer's recovery. Seeing someone else overcome the exact thing you were struggling with, that instills a kind of raw hope that an individual therapist just literally cannot provide. Of those 11 factors, a few are truly transformative. There's universality, that profound relief of realizing you aren't alone. There's catharsis, a totally safe, uninhibited emotional release. Patients even subconsciously project their family drama onto other group members, which actually allows them to resolve old family conflicts safely right there in the room. But, it is a delicate ecosystem. Just one paranoid member consistently breaking boundaries can severely derail that entire dynamic. Let's move to and see how this builds. Because every group goes through these inevitable stages of development. You start with forming to establish ground rules, then you hit storming, where personalities naturally clash. And while you might think conflict is bad, it's actually required. You have to push through that storm to reach norming, where real trust is established, deep disclosures happen, and the primary therapeutic work actually gets done. Finally, there's adjourning, the formal disbandment of the group. This brings us to the ultimate clinical challenge, Section 4, Rethinking Addiction Pathology. Now, what's really interesting about this is how modern clinical practice has completely reframed addiction. We no longer view it as a moral failing or a lack of willpower. It is a complex, chronic disease. Addiction fundamentally hijacks the brain's reward circuitry, specifically the dopamine pathways deep in the brain. Clinically, we view this pathophysiology as a tragic, maladaptive attempt to self-soothe. The patient is desperately trying to fix a deeply rooted internal imbalance or chronic emotional pain by using an external substance. Because of this understanding, the way we diagnose this has radically evolved. The latest DSM-5 eliminated those confusing old labels between abuse and dependence, and it lowered the diagnostic threshold so people can get help way earlier. Crucially, it recognized that behavioral addictions, like pathological gambling, can hijack the brain exactly like chemicals do. The etiology is multifactorial, meaning it heavily incorporates genetic predisposition, trauma, and a person's environment. And honestly, this gets even more complex when we look at co-occurring disorders. Physiological dependence and withdrawal almost never happen in a vacuum. For example, women with addiction often present with untreated PTSD, requiring incredibly collaborative, trauma-focused care. Older adults demand a highly tailored approach too, navigating age-related cognitive changes, higher sensitivity, and the frankly dangerous interactions of complex polypharmacy. Vulnerable populations absolutely demand highly tailored, person-centered treatment. That brings us to our final section, evidence-based addiction interventions. We've looked at the neurobiology and the diagnostics, but how do clinicians actually triage addiction patients to the correct treatments? Well, they match the intervention to the target. If someone is ambivalent about quitting, you use motivational interviewing to tease out their own internal desire to change and build self-efficacy. If you need to enforce strict sobriety from stimulants, you might use contingency management, literally using operant conditioning by offering tangible rewards like vouchers for clean tests. It's incredibly strategic. And in broad healthcare settings, the SBIRT model is used for early detection before things severely progress. But the toolkit goes even deeper. Advanced interventions like CBT and mindfulness train patients to spot environmental triggers and build adaptive coping skills rather than automatic behavioral responses. Other specialized trauma therapies, like EMDR, target the literal feeling state linked to those cravings. And because addiction damages the whole family system, systemic interventions and 12-step peer support are absolutely vital. Through all of this, psychiatric nurses and clinicians maintain a strict therapeutic frame to navigate the chaos. So what does this all mean for the patient? I want to leave you with this final, somewhat provocative thought. In modern clinical practice, relapse is viewed not as a treatment failure, but as a persistent risk triggered by conditioned environmental cues or stress. If we accept that, how does that change the way we define multidimensional, lifelong recovery? It means recovery isn't just a finish line you cross, it's an ongoing process encompassing health, home, purpose, and community. The Therapist Toolkit is vast, for sure, but ultimately, the goal is always the same: helping individuals navigate the complexities of their own minds to build a deeply meaningful life. Thanks for taking this dive into the toolkit with me today.